So now that this session is recorded, being recorded, people are still joining, so we give a few more minutes, 1 or 2. But by all means, say hi to each other, leave your affiliation or contact details if you like in the chat. You cannot unmute yourself without my permission, just to guarantee that the platform is suitable for talks. Our speakers are all online and they're ready. We tested their slides, tested their sound. We will be ready to roll very soon. And on the share screen, you will see the program, the detailed program for today. The session will last about an hour. We are okay to run over time. That's no problem. And if you have questions anytime, you can pop them in the chat, or if we have time at the end, you are allowed to ask unmute yourself and ask as well. Now it's 3 minutes past. I will give 1 or 2 more minutes, then we will start the talk. Welcome, everyone. Continue to welcoming more people, and I'm quite pleased to see. Yes, by all means, say hi in the chat, share your affiliation and contact details if you like. The session is being recorded, and the recording will be shared later as well. Now I can see many familiar names. Max, are you online? I need to unmute you.
Yes, hi everybody.
Yes.
Good to see such a large turnout. For those of you who missed all these talks at Aortic like I did, I'm looking forward to getting the chance to hear them all.
Looking good, looking good. We are still having people joining. I'm very, very pleased. But I will start in a minute. So welcome all. The program for today's session is on the share screen, so you will see we have 6 talks planned. And we'll start with myself giving an overall about AFCIN in the past 12 months. And then I will let the following speakers introduce themselves. And okay, I think we are ready. So once again, thank you everyone for joining. Very welcome to this AFCIN annual session, which we aim to give you a snapshot of what we have achieved in the past 12 months. And this event is under the overall umbrella London Global Cancer Week workshop whole scheme, event scheme this week, that a lot of talks are ongoing during this 5 days, and all the topics concerning cancer healthcare in developing countries, not just Africa, but all over the globe. So let's begin. I can see ticks. I will stop sharing this housekeeping and start sharing my talk. So this is a familiar talk to many of our colleagues, but to those who are not familiar with who we are the African Cancer Registry Network. The talk is about what we have achieved in the past 13 years, and especially focusing on activities in the past 12 months. So this is a global map, and each region is coded by color. And where we are looking at today in our talk is the yellow bit, Sub-Saharan Africa. We are the consortium of all the functioning registries in that continent. And as a hub, we are providing support to nourish the cancer registration world activities within these countries. So up to date, we have 35 members in 24 countries. As you can see the dots around the map. And as the expertise grow, we started 4 centers of expertise around the map. And I will briefly introduce them as well. In Abidjan, Côte d'Ivoire, the hub provides technical support to all Francophone countries with their developments and technical support. Like we have Nairobi, Kenya, who provides all the training support programs for English-speaking countries. And then we have down south in South Africa, which is focusing with the research. One is the cervical linkage, and then pediatric cancer registration, which Natasha will be giving talks on. And then we have a latest baby, which will be based in Luanda, in Angola. The center will be focusing on providing support to Lusophone countries. And then integration is planned early next year. So we have not got a picture yet, but we look forward to seeing the team very soon. So as an AFCIN, our overall goal is to increase the number of registries on the continent. While for the existing registries, we aim to improve the quality of their data in quantity and in quality as well. To achieve that, we're focusing on 4 scope of work. By color, you can tell in training, with facilities and funding available, we aim to have in-person trainings and also e-learning, which allows registrars to do their own studies on their own pace. I will give a bit more information on the e-learning program shortly. And then we will provide expertise on the site evaluations and technical support as well. While the data is mature, as they become available and quality allows, we will be looking at publications, help them to prepare articles or reports. And never forget that advocacies are just as important. We must let our funders and politicians know that the importance and the necessity of cancer registries in the country as part of the nation cancer control program develops. So this is what we do. We don't do it ourselves. We work with our counterparts in the countries. We are focal point principal investigators in the country to on this each field. So I briefly have a snapshot on AFCIN data. So as a network ourselves, we do annually call for data submission. So AFCIN does have an AFCIN database. What do we do with that? So this is a quite familiar fact sheet from the WHO, International Agency for Research on Cancer, for each country. As a WHO agency, they do this estimate for each country every 2 years, and you can see a lot of details, information on the incidence, mortality, prevalence. But all these estimates were only available or possible to be made based on our actual data from these registries. So for countries without actual working registries, the estimates were done by based on neighboring countries, which is not very satisfactory. And therefore, also part of our aim is to help this country to establish their very first registries. Besides that, the data are also used for other estimates, prepare national estimates. If you visit this called Cancer Today, if you search online Cancer Today, you will be able to access this website that you see on the left. It's a very useful website providing a lot of detailed data information, which is free and also based on actual data. And then on the right-hand side are the reported cases. These are the report based on reported cases, and they're also available on the IAC website. In the last volume, the latest volume, volume 12, the cancer incidence in 5 continents, volume 12, from Africa, we had 11 registries being accepted, meaning they met the international criteria. So that was quite an achievement from our side, from rather minimums below 5, suddenly gone over 10. That's doubling. All thanks to the financial support and technical support coming from the vital strategies under the Bloomberg Data for Health initiative. So besides all the international estimates, websites, and publications, we do have regional publications. And these publications are available free for download on websites such as IARC, UICC, or eCancer. Numerous publications on PubMed as well. If you are interested in any topic, by all means search on PubMed. So in terms of what we've done within the network, what we have done beyond the network is that one of these major achievements in the past 12 months, I have to say that Max Parkin himself has single-handed contributed more than 50% of the knowledge into building this platform, not platform, but this whole learning series. You can see that it covers 15 modules, 15 topics, and this website is available, not website, this training program is now available on IAC website. If you go to IAC and go to e-learning, you will be able to find a link for register and start your training. Now it has also been migrated to the WHO academic web platform as well. So you can also go to the WHO website and search for that and enroll yourself. You can do the course over 12 months on your own pace. It's free. It doesn't cost you anything. And once you finish 12 modules, you will receive a certificate. That qualifies you as a registered. And then another piece of important achievement is that based on our own knowledge, we were able to prepare and improve these 2 staging menu, one for adult and one for childhood. These menus are for the use of registrars when they want to stage cancer cases. When they see a clinical record, but without stage written down by the clinician, they are able to do the stage themselves. That is a power in empowerment to our registrars, allow them to provide stage information to the cancer cases. Another important achievement, which is a legislation template, maybe a little bit less familiar to many of you, but many of you would have come across being shut the door by hospitals saying that we have patient privacy protection. You are not allowed to come to collect cancer data anymore. And this is the template that we aim to provide to countries so that the government can establish legislation allowing our registrars to lawfully, rightfully collect information without being hassled. So this will be available as a technical report by IARC very soon, hopefully by the end of this year. And some of this, another major research studies that Jubri will be talking about a little bit. It's a series of research studies looking into different aspects with a different aspect of focus. on under each of these studies. For example, the top one, NORA Care, they look into stage follow-up and interview on cancer care received, and also treatment concordant. And then we have Circam Plus and ServCare, which will look at staging plus survival as well. And Plamena will be giving an overview on these topics. DHIS2, that's another IT. It's very popular topic at the moment. Everyone is talking about using electronic medical record systems, talking about AI, everything. But nothing is as easy as it said. We have spent months and months on developing this DHIS2 oncology module, which is suitable for cancer registration, for cancer registrar to use. And we are testing the implementation in a few countries such as Jamaica, Kenya, Tanzania, and Zimbabwe to make sure that it's actually working for us to our benefit rather than being obstacles on the way. So this is coming along to us very soon, will be available to many of us very soon, hopefully. Last but not least, thank you. This is the team. We just had our latest annual meeting in Abuja, Nigeria last month. I believe all our speakers are in the picture, and if you can spot any of us, feel free to say. So I think this is my talk. Thank you for listening. I will hand over to Natasha as the next speaker. Let me find her, unmute her first. Stop sharing. Natasha, by all means, introduce yourself.
Sure. And just try to share my screen. Just gonna do it again. There we go. So good afternoon, everyone. My name is Natasha Abraham, and I'll be talking about childhood cancer registration, specifically in the context of cancer registries in Africa. So childhood cancers are defined as cancers in children aged 0 to 19 years old. So this includes both our sort of traditional age group of children, which is 0 to 14 years old, and also adolescents aged 15 to 19 years old. And I think a lot of us this week have been hearing through this London Global Cancer Week, but also in other forums, that there's been a sort of very resurgence or a lot of momentum behind childhood cancers in the recent years. And the reason that this was happening is due to the Global Initiative Childhood Cancers by WHO. What this initiative wants to achieve is at least 60% survival in all children suffering from cancer. I think we all know that children diagnosed with cancer in low middle income countries tend to fare worse compared to children in high income countries. So this initiative really wants to address the inequity in survival between low and high income countries. And the other important thing that this initiative also highlights is the 6 index cancers. So what they have done is they've I'm trying to look for my pointer. So what they've done is they've identified 6 index cancers. And what they've said is that if countries can invest in the diagnosis and treatment of the 6 index childhood cancers, inevitably they will be improving the diagnosis and outcomes across the wide spectrum of childhood cancers. So that's something for countries to think about. And now I can't move slow. Okay, there we go. So as cancer registries, our role really that's been highlighted by both the GICC, but also the New World Cancer Declaration that was recently released, is really to provide accurate population-based cancer data. So we provide, accurate stats as the starting point for countries to decide how they're going to allocate their resources, but also for monitoring and evaluation purposes, the data generated by cancer registries become important. So in terms of childhood cancers in Africa, we know there's limited data available on childhood cancers in Africa. So we really, really need to work on trying getting reliable numbers at population level so that, as I mentioned before, we can have better planning and evaluation of cancer services. We do expect the childhood cancer incidence to rise due to improved diagnostics in the future years. We know the pattern of childhood cancer is different to the world, so we really need to have our own understanding of childhood cancers in Africa. And there's a need for correct coding and classification of childhood cancers by registry. So let's look into the technicalities of childhood cancer registration in registries. So of course, the first step for the cancer registry would be to identify the data sources. So we would expect places like hospitals to be a very obvious one, but what we want to do is to concentrate where services on children are provided. So remember, obviously the pediatric wards, but also wards like ophthalmology, orthopedics, dermatology, and neurology are important sources to identify childhood cancer cases. Laboratories are very important because that's where we would find the hematological malignancies through the bone marrow examinations. We also want cancer registries to think of sort of non-traditional sources. So that would be your NGOs that, might be dealing with childhood cancers. We know that there might be specialized databases. There might be a certain clinician who has a special interest in a certain childhood cancer. So that can also be a good data source for identifying cases. We know that there might be clinicians in private practices who might also be identifying cases. So these are all sources that cancer registry should consider. Of course, once the registry has identified this case of childhood cancer, we have to classify it. Now, as cancer registry, we specifically use the international classification for oncology. Right now, we're on version 3. And what this classification system does is it really allows us to have more precise classification of tumors. So it gives us a lot of details in terms of the morphology and the topography. It also allows us to classify cancers in a very standardized way, which allows us to compare cancers across different registries worldwide. So once we've classified it into ICD-03, there's a special classification system for childhood cancers that the cancer registry will then convert it into. So the the International Classification for Childhood Cancers currently is also on its 3rd edition, and there are 12 main groups as listed over here. So it goes from leukemia, lymphoma, central nervous system, neuroblastoma, retinoblastoma, renal tumors, hepatic tumors. We have malignant bone tumors, soft tissue sarcomas, germ cell tumors is an important group, other malignant melanomas, and neoplasms, and other unspecified neoplasms. In cancer registries, in the African context, a lot of us use CanReg 5, which is the software provided by IARC. So the conversion of ICD-03 to ICC3 is built into CanReg 5. So this is usually not a problem at all for African cancer registries in terms of the conversion, and it's of high standard. So our next step in terms of childhood cancer registration is also to look at staging. When we capture a new case of childhood cancer, we also want to know what stage this cancer was diagnosed at. And once again, for childhood cancers, there's a very specific staging system that needs to be used by cancer registries. It's called the Toronto Staging System. A group of experts sat down and realized that there isn't a sort of consistent, standardized way for cancer registries globally to report on staging. And so that's how this staging system came about. As you can see, this guideline is very much intended only used for population-based registries. It's not to be used by clinicians in a clinical setting. This is really for us to be able to capture and compare standardized staging across registries. What's also very important about the staging system is that it has 2 staging tiers. And so it caters for a very resource-specific staging system. So we know that high-income countries, they have very fancy diagnostic systems that they can do a lot of molecular testing, but that might not be necessarily available in other places in the world. And so they have a sort of low resource setting staging system that can be used where there is no fancy diagnosis available. So just for example, if we look at non-Hodgkin lymphoma, we have the tier 1, which is for a sort of limited resource setting, and tier 2, which would be for a sort of high income country where they have lots of fancy diagnosis. So you can see the tier 1 requires sort of very minimal data to be able to stage, whereas tier 2 requires a lot more detailed information for you to be able to stage this childhood cancer. Now you might say, okay, I want to look at childhood cancers in Canada versus South Africa, and South Africa uses tier 1. How would I be able to do that if Canada uses tier 2? So what's really nice about the system is also that the tier 2 is able to collapse into tier 1. So if a country is staged using tier 2, we're still able to actually convert the tier 2 staging into tier 1 and still do a sort of direct comparison. So just for example, if a cancer is staged as stage 2 in a sort of high resource setting, we can then collapse it into limited in the tier 1 and then compare. So just a bit of background as to how I'm here talking about the childhood cancer registration. In 2022, South Africa was named as one of the IAC Center of Expertise, being touched on this a bit earlier on. So really, we are here to provide expertise on childhood cancer registration and cervical cancer linkage for the African region. And in terms of childhood cancer registration, what we really do is to provide targeted support and advice to the registries. So the different adaptations that they would have to consider when they are registering childhood cancers, so that we can have high quality data that can be used for childhood cancer control. So the sort of first step was I was trained as a master trainer by Child GICR. So you can see this is one of the meetings that we had where we were trained by the IAC group and experts. The way the Center of Expertise work is we provide training regionally, so this can be in person or hybrid. So this is just a photo of me with Eric, and we had a chance to visit Tanzania, and we had a chance to train all the registrars from the 5 different population-based registries there on the sort of principles of childhood cancer registration. A lot of our training does focus on staging of the childhood cancers using the Toronto Staging Guidelines. We've also created the childhood cancer registration material as part of the GICI e-training series, which is available for free. Just in terms of our experience and what we've learned from being in the field of challenges of childhood cancer registration within our continent, is I think one of the first things is really the high turnover of staff that we find at registries. Cancer registries usually are not very well funded, and we don't have a lot of consistent, sustainable funding. So we have staff that come in, we spend a lot of time and energy training them, and then you come back a few months later and you realize the staff has changed, they have new staff, so you have to start the retraining again. Staging is complicated. Just because it's in children, it doesn't mean it's any easier. So it does take quite intensive sort of training sessions with sort of multiple repeats before the staging, can sort of be implemented correctly in the field. Identifying all the data sources is often not easy. It may seem straightforward, but it's actually not once you're in the field, especially when we think about the sort of older age group of the 15 to 19 years old, the adolescents. Their sort of referral pathways in the medical setting may not be similar to someone who's age 0 to 14. Private sector can often be difficult to access and get compliance from. Collection of vital status can be quite labor intensive. So we do need extra resources, sort of funding to go out back into the clinic and try find follow-up information so that, if the child is still alive or dead. And often we find that childhood cancer surveillance is not a priority. They're very rare compared to adult cancers. The numbers are smaller. So often trying to convince a sort of, and get buy-in from a ministerial point of view can be difficult when the numbers are so low compared to adult cancers. And also not to forget, in our setting, we often competing with infectious diseases, that tends to happen at more large scale within our context. So, yeah. So thank you. That's all from me.
Thank you so much, Natasha. Let me put my phone on. We have our next speaker, Dr. Francis Zett. I'm going to unmute him and allow him to say hi and introduce himself.
Hello.
Thank you so much, Natasha. Thank you. Francis, the stage is yours.
Okay. Good afternoon. Hello. Okay, so I'm Francis. I'm a pathologist from Tanzania. I'm also a director of the Dodoma Cancer Registry and located at the Benjamin Mkapa Hospital in Dodoma, Tanzania. So my session will be developing a national registry program. And I'll talk a bit about our experience as a country.
He said you are in a lecture mode. I don't know whether you want to change to speaker mode or presentation mode. It's up to you. Just let you know.
So you can. Okay. Can you see? You can see my screen, right?
Yes, can see a screen. Yeah. Now it's on the PowerPoint mode.
Okay, that's okay. So Tanzania is located in the eastern part of Africa, along the Indian Ocean, along the coast of East African Indian Ocean. And cancer registration, as we all know, is a cornerstone for effective cancer control and public health planning. In our country, the Ministry of Health control all the population-based cancer registry with the technical support from Vital Strategies and African Cancer Registry Network. The main challenges that we have a limited data disease surveillance, especially for non-communicable diseases like cancer. Most of these diseases are not notifiable diseases so far up to now, but also we do have a fragmented data systems. We have different sources. We have different systems that collect these informations in different areas, and these systems are not integrated. So these are the main challenges that affects a comprehensive cancer control, cancer monitoring in our country. But there is a growing need for population-based health registries to ensure the data are quality, and also the quality data collected and also utilization. Why do we need reliable cancer data? Because we need for evidence-based planning and decision-making. We also need reliable cancer data for efficient resource allocations. And also we need for evaluation and improvement of cancer prevention and control interventions in different regions. In our country, we do have 5 population-based cancer registries, and each registry has a director and cancer registrars. And the coordination of all this, as I said, is through the National Cancer Coordinator, who is located at the Ministry of Health. The population covered by all these registries is approximately 6 million people. And this is a snapshot of our governance and coordination of our registries. We start at the lowest level, which is the cancer registry itself. Then this is supervised or overseen by the Regional Sub-Advisory Committee for Cancer Registry, which has overseen the regional implementation, ensure that the registry follows the national standards, and also facilitates the communication between these registries and the Ministry of Health. But also we have the National Advisory Committee for Cancer Registry, which provides national leadership, policy guidance, and coordination across ministries. And then we have the central coordination unit, which controls all the activities for cancer registration, and it's responsible for guidance, operation supports, operation procedures, data quality and frameworks, and also the roadmap for our cancer registries. So I will also give you the snapshot of the cancer data in our country. And we can see the data from GlobalCan 2022 published to Tanzania, which were estimates according to data that were sent by the population-based registries. We can see the number of cases and number of deaths are almost half of the cases, and the prevalent cases are about 90,000 as shown. And the top 5 cancers for both sexes were mainly so the cervix was the most common, followed by prostate, breasts, esophagus, and colorectal. And if we look at them and according to sex, then you can see prostate is leading males, and cervix is leading females, and esophagus is second for males, and breast is second for females. We have also childhood cancers, and we have seen the categories of the childhood cancers. And our leading neoplasms for childhood cancers, we have lymphomas and reticuloendothelial neoplasms, we have retinoblastomas, renal tumors, and leukemias and myeloproliferative diseases. These are the top leading malignancies in our country. Data quality improvement and challenges. We have, for data quality improvement, we do have a periodic data quality evaluation. And also, if you can recall, we also have the regional subcommittee also ensures that this is performed. But also we have registry level improvement plans and central validation from IRC and national experts. So the challenges are similar to mostly limited human resource variability in diagnostic capacities, because different regions have different capabilities for diagnosis, pathology, radiology, and lab capacities. For data reporting systems that are not integrated, and also sustainable funding mechanisms. So this is our milestones in our country. We started around 98. And when we started, it was a hospital based, but you can see that up to 2018 we have had 5 cancer registries, and then were established. And then in 2025 we had a central coordination unit and national advisory cancer committee, which was launched this year. So we are looking forward to expand registries, as we can see that we have had quite a small population is covered, and also integrate the use of DHIS2 for registry, and also establish a centralized cancer database in the country. So this was the committee which was launched this year, which will be working on to coordinate all registries, quality controls, and all other guidelines, as I said. So in conclusion, our registries network continues to grow through Ministry of Health and vital strategies support. Collaborations and sustainable investments are key to success. So our experience highlights the importance of the strong leadership and partner collaborations, structural implementation, and the continuous improvement to ensure that the data, the registries keep on growing. We to grow and strengthen our registries, but also to expand and to ensure that all these registries, they do have a quality and reliable cancer data, which are very important for consumption and implementation. Also, there is importance for building local capacity for sustainable, data-driven, healthy policy. And with that, this concludes my presentation. Thank you very much, and welcome to Tanzania.
Thank you so much, Dr. Francis. Now we have our next speaker, Jibril from Burkina Faso. The stage is yours.
Yes. Okay, so thank you, Bing. I want to share my screen. Okay.
Yeah, it's coming.
Okay, d'accord. So it's good?
Yeah, good, thanks.
Yes, thank you very much. I'm Jibril Tionsa, and so I'm from Burkina Faso. I'm Ouagadougou Cancer Registry Data Manager, and I'm also a regional trainer for African French countries. So my speaking is about collecting information on stage in population-based cancer registry in sub-Saharan Africa. So what's very important, staging cancer is important for regional planning cancer control at a national and regional level for development of and target and effective intervention for early detection and treatment to improve patient outcome and for optimal allocation of limited resources in limited system facing multiple challenges in our country. Despite this importance of staging, there are few challenges. Critical lack of information on stage at diagnosis in cancer surveillance data in sub-Saharan Africa. According to estimate, we have less than 30% of cancer cases have complete information on stage, and limited diagnostic infrastructure and unequal access is also a challenge. And we have also fragment and missing help for information system or for data from collecting a method. That's why African Cancer Registry Network recommend the registry, cancer registry collected the information about stage adult cancer by using essential TNM and stage 1 to 4, and for pediatric cancer by using a Toronto system. And this way, you save the risk where the cancer registrar of our cancer registry collected information about stage and about TNM. So what about adult cancer by using TNM essential? The essential TNM is a simplified TNM classification. We use a reverse flow system and a practical flow chart to extract the information about a stage, and it permits also a standardized stage information abstraction with all cancer registries in sub-Saharan Africa. So the important is know how can I use the TNM essential? To use essential TNM when the full TNM is not explicitly recorded in the patient clinical record or pathological report, so the cancer registrar should attempt to extract the stage information according to essential TNM scheme. We have three steps to extract essential TNM stage from medical records or pathological report. The first step is about the presence or absence of distant metastasis. If you have metastasis recorded in patient clinical record, we have M+. If there is no information about the metastasis, we have M-. The second step is about the presence or absence of regional lymph node. If your involvement of regional lymph node is recorded in medical record or pathological records, we have R+. And if you are not involvement of regional lymph node, we have R-. And note it, we have two subdivisions of regional lymph node. We have R+ and R2 to mark the extent of the regional lymph node involvement. And the final step is about the size of a tumor extension. And in this step, we have two categories. We have advanced and limited. Advanced size and tumor, we have two categories, A1 and A2. A limited size and tumor extension, we have L1 and L2 to mark the extent of a tumor mass itself. In this slide, we see the map of the mapping of information to extract information according to each essential chain. This is the column diagram. You have clinical information, so you can base on this flow chart to extract the information about stage information. So the essential chain, what is the essential chain impact about cancer staging? The using of essential chain is about reducing gap in staging in our country, permit a significant improvement in data completeness in Sub-Saharan Africa, facilitate international comparability between our cancer registry and between other cancer registry in other countries, and it permit our data integration into initiative of global integration of all data and initiative. So we speak about TNM essential. So we have to speak about pediatric cancer by using a Toronto system. A Toronto system, like Natasha said, is a consultative guideline for pediatric cancer for 0 to 14 years for population-based cancer registry. Is adapt various contexts like our African context. And Toronto system cover pediatric cancer, pediatric leukemia, lymphoma, nervous system tumors, and solid tumors. The Toronto system provides a too flexible level for staging pediatric cancer, but the tier 1, the level 1, is more suitable for our cancer, our context, African context, because it's less detailed, suitable for limited resource registry, collecting for minimum essential staging information, and is easily applicable in most African context. That's the important point. And to show the importance of extraction of stage by the cancer registry, we conduct a last study to compare the certification of cancer registrar by between cancer study extraction from clinician. So, what is the correlation of this study? A single training remaining in study result in accuracy similar to that observed in clinical situation in high income setting. That is show after the study, this study show there are not big difference between staging abstraction by cancer registrar with a clinician certification. Donc, so, and this is show the importance of training to extract the information in the clinical record to reduce the gap of cancer staging in Sub-Saharan Africa. Data quality. How to improve our data quality? I say target training programs, development and outsourcing of digital tools for data management, strengthening collaboration between clinician, pathological, and cancer registry, and strengthening collaboration with regional help for sharing expertise and harmonization. In conclusion, staging is a fundamental pillar in the fight against cancer in Sub-Saharan Africa. And the essential TNM and Toronto system are adapted to context of Sub-Saharan Africa countries. Significant progress has been remained in adoption of this system, but significant challenge will remain. And we have some recommendation for according to the staging in cancer in Southern Africa, is to promote the systematic adoption of a TNM essential and Toronto system in all cancer registries in Southern Africa, and support research on the quality of staging, strategic partnership with institutions, AYAC, FCRN, regional hubs, and at the end, extend the chain essential site to reduce the gap of staging cancer in Sub-Saharan Africa. So thank you for your attention.
Thank you so much. Thank you so much for speaking in English as well. Jubre is a French speaker, so he has done a lot of practice to give this talk in time and
Yes,
make
yes,
sure
yes.
you
Thank
can
you very much.
understand as well. Thank you so much. So, so we will have our next speaker, Pramina. Let me find her name and allow her to unmute and introduce herself. If you could stop sharing, Jubre. Okay, thank you. Yeah. Whenever you're ready, Pamela.
Yes, just a second. Now you should be.
Just a quick word to say that we are a bit over time, but I hope that our talks are interesting enough to keep you guys here. Thank you.
Okay, I think you should now be able to see my screen.
Yes, on. Thanks.
Correct? Yes. Good afternoon, everyone. I'm very happy to be here. I'm Plomena, and I'm a PhD fellow at Martin Luther University in the Global Health group of Professor Kantelhart. And today I'm going to present the studies we conducted using the cancer registry data. So our studies are NORA-CARE, SERVCAN, and SERVCAN Plus, and these are studies on cancer surveillance. That is the aim. The design is a retrospective population-based cancer registry cohort study. We involved in the studies were 20 cancer registries from 14 countries in Sub-Saharan Africa, and we collected clinical information on tumor-specific parameters, therapy, and follow-up, as well as information on barriers to care and access to care obtained from personal interviews. As being mentioned at the beginning, these three studies are complementary. In the core of all of them was NORA-CARE, where we collected the information on survival, clinical evaluation, and personal interviews. Then SERVCAN Plus was a study where we collected survival plus clinical information, and SERVCAN where we collected survival only. So how we did this, in the first step, the cancer registry provided their data to AFCRN, where AFCRN pre-processed this data and provided to MLO a randomized cohort sample. In MLO, so Martin Luther University was made the setup and the infrastructure for the data collection, as well as the development of the questionnaire that served as a basis for the data collection. And in the fourth step, the data collectors went to the centers and searched for the files, as well as connected the patient themselves. And basically, the data was collected. And after that, the data was after processed by the students in Martin Luther University and shared with everyone who participated in the study. So The questionnaire basically consists of 3 domains, the cancer registry data, the clinical data, and the interviews, where the clinical data and the interviews were built from 15 sections, and 4 of these sections were on survival assessment. Why this is important, you will understand later. And altogether, we collected 350 variables. At the end, we had 12,444 records, and all cancer registry participated actively and provided data. From these 12,444 records, at the end, we had 12,416 records after cleaning the duplicates and test records. And yes, so we had data on 21 different cancer registries, where the most represented were prostate, cervix, and breast, making 30% of the whole data sample. As next, I want to show you how good the data was that we collected. We evaluated the data quality in 2 steps. The first step was by evaluating the validity of the data. For this reason, we used 4 variables that were represented in the both domains, in the clinical file and the cancer registry. We categorized them in match, minor disagreement, and major disagreement. And as you can see here, the result of the data validation analysis showed that the most of the cases were in fact matches. And in the next step, we built a quality score. We basically assigned points system for each match, minor, major disagreement, or missing. And after that, we translated this score into quality for each record. And at the end, we could assess the quality for nearly 83% of the records in the data set, where 99.6% of these assessed records were high to medium quality and less than 0.5% of low quality. As next, as I said at the beginning, the aim of the studies were cancer surveillance, and as you can imagine, one of the the core steps into the cancer surveillance is to assess the follow-up time of the patients. And for this reason, here I want to show you a data sample. So our data is a real-world data, and it contains different sources on the same variables with often controversial or missing information. As you can see here, for instance, for some of the sources, we have just date of last contact without status. For other, we had the same dates, but with a different status, which of course made difficult to decide whether the patient is dead or is still living. Other information showed that the patient is still living after once he was registered as dead. So we had to come up with a method for best guess in order to define the status of date of last contact, which of course was the basis for calculating the follow-up time and addressing the aim of the study, cancer surveillance. So the first rule was basically to take just pair. We had, as I mentioned, 4 sources, and here you can see for how many records, how many pairs, how many sources of information we had. So for instance, 16.9% of the records we had all 4 sources. For 25 we had just 3 pairs, etc. In the next step, we extracted data from the comment section, where a lot of the data collectors noted the date and status of last contact. And in the third step, we developed a decision tree where we ranked and prioritized the different sources, did date comparison, and developed time-based rules. Our goal was basically to cover the majority of the records in our data set, and to define a quality controls to where we can mark the cases that need additional manual review. In summary, we could calculate follow-up time for 96.8% of the cases, with a median follow-up time of nearly 7 months, compared to 1 month from the initial cancer registry data. And at the end, I want just to mention the proportions of lost to follow-up cases on the 3 of most represented cancers over 5-year period, depending on the year of diagnosis. What you can see, what you see here is basically how many people are censored year after year for a time period of 5 years after the date of diagnosis. This, of course, is important for the survival analysis afterwards, because because this reduces the sample size of the survival analysis. And here on the first slide, you see the cervical cancer, where after a 5-year period, nearly 50% of the initial sample is censored, and this is very stable for each year of diagnosis. Breast cancer, it's a little bit different. Here is nearly 30%, and prostate is somewhere between 30 and 40%. And at the end, I just want to thank the AFCRN team, to all cancer registries, to the NORA team for collecting this huge study on cancer surveillance in sub-Saharan Africa, which I believe will result in a lot of insights on cancer care, and hopefully will lead to improvement of public health. Thank you so much.
Thank you so much, Pamela. Yeah, that little short 10 minutes actually require a lot of people on the ground, and this 12 months work, field work, to collect those informations. Oh, I noticed my name is misspelled here, finally.
Oh, I'm so sorry.
Hey, that's all right.
I'm so sorry.
So thank you so much. You may have all your questions in the chat. Gilbert, please pay attention. There's one question for you, and I will let you answer that at the end of the session. And now we will have the last talk. So this talk is being recorded by Gladys from Kenya National Cancer Registry. Right, let me just share before I talk more. So this talk is recorded by Gladys Chamsubai from the National Cancer Registries, Kenya. She's doing field work at the moment, so her internet connection is feeble. So to save our nurse, she has recorded her talk for us. So I will play it. Please do let me know if you cannot hear her voice. I will start now. Thank you. And any questions, please feel free to pop them into the chat. And at the end, I will let everyone unmute and say hi as well. All right, let's start.
Hello, everyone. My name is Gladys Chisumbai.
Can everyone hear her? Is it good? Okay, I will continue.
Nyango. I'm the head of the National Cancer Registry at the National Cancer Institute of Kenya. I also support the African Cancer Registry Network and IAC-GICR as the regional trainer for cancer registration in Sub-Saharan Africa. My presentation today will be on how national estimates are made through the Global Cancer Observatory. Let's have some key reflections. Can you quantify the burden of cancer in your community? Do you know which cancer is the most common and which one is common in male and females? What is the basis of your cancer control strategy? Is there a gold standard for cancer registration that you know about? The current situation of health records and information in African cancer and African countries is as shown on these diagrams. Some facilities are only using paper-based record-keeping practices, while others use a hybrid of both paper-based and electronic record systems. Others have fully migrated to electronic medical record systems. GlobalCan 2022 estimates provide estimates on cancer incidence, mortality, and prevalence for 36 types of cancers at national levels. Each country is able to see their estimates based on type and other features. What is the process of cancer registration? How does this information get into GlobalCan statistics? Trained cancer registrars use a case abstraction form to collect information from the patient file from each cancer diagnosis. They then process this information in form of coding it, in form of ensuring that the staging information is accurate, ensuring that all the information, including age and sex of the patient, is available. This information is then entered into CANREG 5 and then processed further to provide data sets that can then be shared with IAC. National estimates are based on actual data from countries that are concerned and are not statistical models as in other international health data estimates. GlobalCan data are primarily from population-based cancer registries where incident data is obtained. Mortality statistics is usually obtained from vital registration at the vital statistics offices. Specifically for Africa, population-based cancer registries are particularly important for this reason. The data used for the 2022 estimates are not necessarily for the year 2022 in terms of cancer incidents. They are usually for most recently available incidents or mortality for the population-based cancer registries. These are usually applied for estimates for the 2022 data that you are seeing. Population-based cancer registries collect data on all cancers that occur in specific population. This could be a country, it could be a province, or it could be a city. Population-based cancer registries utilize multiple sources of information, and this can be information from clinics, information from hospitals, information from laboratories, information from vital statistics, information from hospices as well. Population-based cancer registries collect data on new cases occurring in a catchment population. This is also known as cancer incidence. We collect information on staging, also information on survival or outcome of the patient. We categorize this information in form of site, in form of histology, according to sex, according to age, according to region, as well as the population. In priority order, information on incidents that is used for global can estimates can be from national cancer registries or subnational cancer registries, which have a coverage exceeding 50% of the population. Information where this is lacking, latest information from a single cancer registry can also be applied. Also, the average of the most recent subnational rates are applied in the 2022 population. All site estimates from neighboring countries partitioned using frequent data can be utilized also for the Global Can 2022. Where there is no data, rates are obtained from neighboring countries or registries in the same area to cover for the lack of data. Based on the Global Can 22 sources, we had 19 countries providing national or regional data from population or national cancer registries. 18 countries provided frequency data, while 8 countries provided frequency data, and 18 countries did not have any data at all. This can also be seen in this graph. The African Cancer Registry Network is a consortium of population-based cancer registries in Africa, in sub-Saharan Africa, that provide activities of IAC regional hub role with respect to cancer registry support in sub-Saharan Africa. The FCRN has 37 members in terms of registries who come from 25 countries, as shown in this graph. Where can you find data on incidents, cancer incidents in Africa? You can find this data from monographs like Cancer Incidents in 5 Continents, a publication by the International Agency for Research on Cancer. You can also find this in monographs on cancer in sub-Saharan Africa, volume 2 and 3. Also, Cancer Incidents in childhood cancer in Africa. There are also numerous scientific publications, country reports, time trends, and survival reports. On cancer mortality, information is usually not available in most of the African countries, apart from Mauritius, Reunion, and Seychelles. Therefore, this information is estimated from incidence and survival information. Most common cancers by country can be generated from the Global Can 2022 estimates. And here on these graphs, you can see the most common cancers in females and males in Africa, and more specifically for females, cancers of the breast and cervix are most common. And for males, cancer of the prostate is the most common cancer in Africa. This would not be possible without data from Global Can estimates. We are also able to look at incidence per cancer for each country.
Oh, I am the host. Sorry, my computer crashed. Where was the presentation stopped? I do apologize. My computer crashed and I couldn't do anything apart from restarting it. So, Pramina, yeah, Pramina, you can talk to me. Tell me on the if you unmute.
No, I just wanted to inform everybody. I'm sorry. Everything is fine. I just
Yeah.
wanted to.
So when was the presentation stop working for everyone?
She was speaking about the most represented cancers, about prostate cancer. I don't know which minute was that exactly, if somebody remembers.
3 minutes, 37 seconds. Okay, that's quite early. Restarting the presentation. I do apologize. It's a very interesting presentation. While I'm trying to restart. Max, I asked you to unmute. Can you come and rescue me here? The presentation is not.
Can you? Yeah, start it about there. It's about 4 minutes or something.
Yeah, a video is not running on the computer. That might have been the reason kill my computer as well.
Let me see if I can. Let me see if I can quickly run through. Let me see if I can do it from here.
Yeah.
Just a minute.
Guys, I couldn't see any of your comments about the video stop either. My computer went frozen and couldn't move.
Can I share my screen then?
Yes, you could. Yeah, please.
Let's try it.
Right, presentation taken over by Dr. Max Parkin from here.
Let me try.
Even better. Thank you.
Not sure it's making it soon.
Okay. That's fine. I can. Oh no, that's the recording.
I did the whole thing from the beginning. Oh, well.
Oh, you want to share that? No, it's when you click share, you have to make sure the sound goes through as well. And there's a special button.
Is it
Or
working?
you can. No, because you need to close the folder. Let me.
Okay, well, I'm not good. Let me see if I can. Let's see if I can put it on full screen. I want to do this one. Is it on full screen or just on speaker mode?
No, just on slide mode. Now it's full screen, yeah.
How's that?
Coming. Did you click that little sign?
Yeah. Not sure I'm in control here, really.
Now speaker mode.
Is it? That better?
Still speaker mode. You may go ahead if you minimize the slides on the right-hand side.
Can you hear me?
I can hear you, yes.
Okay. Okay, I think that's where we got to in Gladys's talk, talking about a global can, wasn't it? Just saying that, as it says here, the data from actual data, mainly from population-based registries, And they're particularly important in Africa. I think that's where we got to. Let's see if I can press the next one. Sorry, I can't manage to get it onto full. Can't manage to progress now for some reason. Okay, yeah, so this was a little bit about population-based registries. I think she was talking about, I think we all know this, what the registries are doing. We're using multiple sources, and it may be registering cases from a whole country, province, or a city, using all the different sources available. And GlobalCan, this was in the text, is using the data from GlobalCan is either national incidence rates, or if we've got several registries in a country, we may use the average of subnational rates, or if it's a single registry in a country, we're just using the data from that, using the rates and applying it to the 2022 population of the country. Or if all else fails, we might have some frequency data that we can use to make an estimate for the country. And if all else fails, then we have to use the rates from neighboring countries. That's not very satisfactory at all. That's just a situation where we don't have anything at all. So this is basically the situation for GlobalCan 2022. It's not quite accurate, but almost. So the blue areas are where we had a national registry. So I think we know these are the smaller countries, Eswatini, the islands there, Botswana, Namibia, and Gabon. And for all the areas in green, we've got one or more registries in the country. So I think all of you are sitting there will recognize the countries you're in, and the orange is the frequency data. There's a registry there. That's Burkina Faso, as Jibril knows, but we didn't use the incidence rates because we're not quite sure about them, but we can use the frequency of cancers to make our estimate. So that's basically how GlobalCan 2022 was made up. And yeah, we've already seen this from Ying's talk. These are the registries around Africa in the AFCRN, 37 registries in 25 countries. And we all know this is what we do. We collect the data from the records. Normally, it's still mainly manual using the paper forms, enter into CanReg, and then the data from CanReg goes around through the AFCRN database that being described, and then we use that to make the estimates for Africa in GlobalCan 2022. And she already said some of this is published. We can find published rates in cancer incidence in 5 continents, just 11 registries at the moment. But I think nearly everybody has been published in these books where we publish the rates from most of the registries in the AFCRN, and hopefully we'll do another one next year. And then, of course, lots of papers or individual reports from the registries presenting some data. So that's where the data is published. But of course, GlobalCan, we can also use unpublished data with the permission of the registries concerned. And up to now, nobody said they don't want their data to be used in GlobalCan. Everybody says fine. Now, what about deaths? Yeah, GlobalCan has incidence, mortality, and prevalence. So how do we get mortality data from Africa? Well, I think somebody already talked about this, wasn't it? Saying that actually there's very little mortality data by course from Africa, just some of the smaller countries with accurate mortality data, Mauritius, Reunion, Seychelles, and so on. So for the rest of us, we have to estimate the number of deaths based on the information we've got on incidence from the cancer registry and survival. So we use national incidence, and then we use the survival to estimate what the case fatality would be. What's the proportion of cases that would die? And then if we do that, we can get an estimate of how many deaths based on the number of cases and the case fatality. So that's basically how it's done. So yeah, where do we get survival data from? Well, I think Pamina's already described what's going on in SurvCan 4. That data is still being processed, but the previous round of studies, I think most of you took part in it, SurvCan 3, we had survival data from 15 countries, plus including one in North Africa and 14 in Sub-Saharan Africa. So 14 registries took part in the previous SurvCan, and it will be even more in the next one, so we'll get a lot better survival data. So there it was. It's been published by IARC You can find it. And also, remember there's a paper by Yvonne as well looking at the SERVCAN3 data for sub-Saharan Africa. So what we do basically is use the survival data we do have, plus some old data from Europe, to look at the ratio of survival against HDI, Human Development Index, basically saying the richer the country, the better survival. So this is, for example, C53, this is cervix cancer here, you can see down the bottom. The scatter chart on the, I'm not good. Oh, here we go. Let me just try using the pointer. Yeah, here we are. If we look at this graph, these dots are survival figures here, over on the right, on the left, against Human Development Index. So you can see the higher the HDI, the better the survival. So countries with a low HDI here have a poor thing. So basically what we do is fit a line to this so that it looks nice and smooth. So for any country along the bottom here, we can predict what will be the survival from cervix. It says breast here, but it says C53, it's actually cervix. So basically that's how it's done. For lung cancer, you can see here, it doesn't matter how wealthy the country is, the survival is still pretty miserable. And that's what the data actually shows. So that's basically how it's done. We've got the incidence data. We know what the HDI of each country is, so we can predict what the survival is. So with incidence and survival, we can make a stab at the mortality. So that's how it's done in GlobalCan. I think most of you know we don't actually have any mortality data from a country, so it's being estimated from your incidence data. So there we are. This is all the stuff from GlobalCan. I think you're all familiar. The top 10 cancers and so on by numbers of cases. What's the most common cancer? I can't remember as being already showed this, or somebody did, Jibril maybe. For females, it's only breast or cervix, every single country. For males, a bit more variable, but the main one we can see is prostate, with a few exceptions. Kaposi sarcoma still down here, and liver cancer in a few countries in West Africa. So that's basically, and we've already seen this. These are the sort of graphs we can look at for the distribution of cancers, different cancers, according to a country. This is the sort of stuff we can generate from GlobalCan. I think we're all. So there we are. That's how it's done. I think Gladys introduced it quite well. And I think most of you know that we're using your data to generate these national estimates. And that's essentially how it's being done. So there we are. If there's any questions, you can pop them online. I don't want to delay it too long. We made the session rather a long one now.
Yes, thank you so much, Max, for rescuing the situation. I do apologize for the technical challenge I had here. So if any questions, please pop into the chat. We are 30 minutes overdue. There was a question for Jubril. What do you do when you look at the clinical files and there's no information for stage? Jubril, I need to unmute you.
So thank you, Being. So thank you to David for discussion. I mean that if you are not no information in clinical record on a particular report, mean that the stage is no. Is no. But if you have some information in the clinical record, but not more information, you can try to use the flowchart of ETNM to try to this information to see if you can extract the information on SAGE. But if you try and you and with this information you cannot extract the stage of this a patient, I mean that the stage is a no. Yes.
Yeah, thank you. Thank you. We pretty much try to salvage anything we can find, and we try to write down as much information as we can on the data set. Max, do you have anything to add to that? I now allow everyone to unmute now. Everyone can unmute.
Right. The answer is the whole point is that stage may not be written in the clinical record. The doctors may not have written the stage. But if you have access to the clinical record and you can read through it, sometimes it's possible to abstract a stage yourself using essential TNM, as Jibril said. Now, if we don't have access to the records, for example, just have a path report or something, there's nothing we can do. But usually in the clinical records, you can get enough information to get an idea of what the stage is using the essential TNM. That's the point of it.
Right. So some people are mute. You are welcome to contribute to the workshop or ask questions here. I would like to close the session in the next 5 minutes. Otherwise, it's good to come and say online and say hi. It's good to see many of you. Some are colleagues and some are new to me. Welcome to unmute and open your camera as well if you do have one.
Hello.
Yeah, so Natasha
Hello.
says good. Hello, we can hear
Yes,
you.
hi,
Hello,
Bing.
everyone.
Hello, everyone.
It's good to see you.
Yes, I need to locate
It's
who's
nice to
talking.
be here.
Okay,
Yes.
Thank you for attending
So
the
happy to
talk.
be here.
It's
Thank
good
you
to
so much for having me. Thank you.
I've been from Zambia. It's good to engage the clinician as well to
Hello?
get information from them. Hi, Anne Curry, please, you raise your hand. I think everyone is allowed to unmute now. Hello. Thank you so much for making your time. And
My camera is there. No,
yes.
just wanted to say this was great. Thank you for organizing. I see that we had very good presentations at AOTIC. I hope you are able to link up with collaborators, partners, funders. Maybe you can tell us a bit about that, whether we were able to meet anyone who may be interested to fund AFCRN. But thank you so much for representing us at AOTIC.
Thank you so much, Anne, for fundraising for us. It's crucial, yes.
Yeah.
If you want to show yourself on camera, feel free to do so. I will just take a snapshot now and I shall release everyone back to your normal life. Thank you so much, everyone. Keep smiling. I'm taking pictures, getting snapshots. Bear with me. All right. Thank you so much, everyone. Thank you for your time.
Thank you, Bing.
Thank you. Have a good afternoon, everyone.
Thank you. See you.
Thank you so much. Thank you. Thank you to speakers. Thank you for everyone.
So
Bye,
much.
everyone.
Really, really appreciate.
Thank you. Appreciate your
Bye-bye.
time as well. Thank
Thank
you.
you, Beam.
Thank you.
Thank you, and thank you, everybody. Really appreciate.
Thank you. Thank you for your time. Have a
Thank you.
lovely
Bye.
afternoon.
You too.
Bye.
Thanks.
Thank you.
Ni wallahi sadda za a ɗauke ni da kodin. Dan lahari wallahi ce duk kwashi kana gaba ɗaya. Wallahi ko da zuwa ya ce ran wande.
Bye. Goodbye for now. Thank you. Bye for now.